guess we need to get a hat to put on, no.
Both
He'll
of you.
get his hat.
Both of you need a hat.
Yeah. Okay. Right, let's go.
Wookie wookie.
Hello.
Who?
Hi, good afternoon, everyone.
Good afternoon.
If everyone would please mute your phones until it is time for you to speak. We want to welcome you to today's COVID-19 Health Equity Task Force. I'm Katara Williams, Chief of Staff here at Southern, and we will begin this meeting with a roll call. Ms. Gerald?
Good afternoon. Dr. Sandra Brown,
Here.
Dr. Thomas Levice,
Here.
Senator Regina Barrow,
Thank you.
Dr. Earl Benjamin Robinson, Dr. Takesha Charles Davis, Dr. Rebecca G., Dr. Corey Hebert, Reverend Theron Jackson, Mr. Raymond Jetson, Dr. Peter Kasmarsky,
Here.
Dr. Kathleen Kennedy,
Here.
Mr. Michael McClanahan,
Here.
Dr. Orlando McMeans, Representative Dustin Miller, Ms. Judy Morse,
Here.
Dr. Demetrius Porsche, Dr. Ronnie Whitfield,
Previously installed in the New York State Legislature.
Dr. Gary Wilkes,
Here.
Dr. Ray Belton, Dr. Katara Williams,
I'm here.
Secretary Kimberly Robinson, Secretary Robinson, Dr. Adrian Wilson,
I'm here.
I
This
have
is
you.
Secretary Robinson.
Okay, thank you. Dr. Victor Jones, Dr. Kim Hunter Reed, Ms. Delesio Alford,
Here. Here.
Dr. E.G. Geary, Dr. Eric Van Home,
Here.
Ms. Alma Stewart, Mr. Christopher Tyson, Dr. Alicia Bates,
Here.
Dr. Mary Meg Brown,
Here.
Ms. Leanne Fowler,
Here.
Mr. Tavell Kendall, Ms. Cindy Snyder, Ms. Carol Smith, Ms. Kathleen Tate, Dr. Janine Thomas,
Here.
Dr. Christy Anderson,
Here.
Dr. Renato Banks, Dr. Banks, Dr. Keith Ferdinand,
Here.
Dr. Keith Ferdinand, Dr. Ebony Price Haywood, Dr. Robert Maupin, Dr. Connie Arnold, Dr. Terry Davis,
Here.
Dr. Margarita Echeverry,
I'm here.
Dr. Peter
Here.
Fox. Yes, ma'am, I have you.
Peter
Dr.
Fox here.
Foss, Dr. Faye Grimsley, Dr. Amy Lesson,
I'm here.
Dr. Rhoda Reddix, Dr. Daniel Sarpong,
Present.
Dr. Lisa Van Hoos,
Here.
Miss Shalina Davis,
Here.
Dr. Amanda Dumas,
Here.
Miss Kristen Engel, Miss Tina Granger, Miss Catherine Haywood, Mr. Rudy Macklin, Miss Tiffany Netters, Miss Netters, Miss Erica Rogers, Dr. Derek Ravaris,
Here.
Mr. Frederick Thomas,
Here.
Dr. Ziad Ashkar,
Hello.
Dr. Ashkar,
Hey, hold on one second, Charlie. They called me roll right quick on my task force meeting. Hold on one second.
Dr. Ashkar, Dr. Jacqueline Harris, Dr. Simone Rambati.
Here.
If you did not let me know you were here, do you mind saying your name for me, please?
Victor
Dr.
Jones, Board of Regents.
Dr. Benjamin Robinson is here.
Theron Jackson is here.
Dr. Ronnie Whitfield is here.
Dr. Kathleen Tate, Northwestern State University.
Cindy Schneider, Franciscan University.
Anyone else?
Erica Rogers is here at Braveheart Foundation.
Dr. Kathleen Searles is here at LSU.
What was the last name? Sarah. Okay, I have you.
Dr. Robert Malpin wanted us to let you know that he had a department meeting right now. He
Yeah.
regrets his absence.
I have it. Thank you. Anyone else? That's it.
Okay. Thank you, Ms. Gerald. Just a reminder to everyone again, just to please mute your phone so that distractions are limited during today's deliberations. Also, if you have any public comments that are germane to this agenda, the staff is standing by to receive those comments. You can send us an email at public_comments@sus.edu, or you may call our line at 225-771-4364, which is a line dedicated to receive public comments. You can also log on to our website at www.sus.edu, where there is a Health Equity Task Force link, and there you can submit your comments electronically directly to us. Today we have a pretty aggressive agenda to get through, but definitely a great agenda to work through. We are starting to see some of the fruition, some of the work come to fruition of some of our subcommittees. And so we'll be able to hear some of the outcomes from 4 different subcommittees. And I will turn it over now to Dr. Brown so that she can talk a little bit about that, or Dr. Leviste.
Hello and welcome everyone. The process for today, as you know, we're approaching our 30-day deliverable. And so we have 9 priorities. 4 of the subcommittees are going to be presenting today. You will have 20 minutes to present in totality so that we can move from one group to the other. The executive task force has received your reports. They will be reviewing your reports. If there are any recommendations or changes, we will notify you of those recommendations and changes. And our process is to forward the reports to the governor as we receive them, if they are, editorially correct and ready to go. So half of the subcommittees will be presenting today, and hopefully if the rest of the subcommittee groups are ready, they will present on next Friday. Dr. Leveist?
I'll be happy to close out the meeting. I just wanted to add, in terms of opening the meeting, is that the process that we're going to undertake is that we'll have the reports presented at this meeting. I know that most of you haven't had time to read the reports on the executive committee. So we're going to discuss them at this meeting, but we will formally vote next week about whether or not to adopt the reports and forward them to the governor as a recommendation from the task force. So that'll be the process that we will follow.
Okay, we will move forward with the first subcommittee, which is the COVID-19 testing for vulnerable and at-risk communities. Please identify your name, your co-chair's names, whoever will be presenting, and identify the members of your subcommittee so we can make sure that they get the recognition as well.
Good afternoon. I'm Meg Brown. I will start the presentation for our subcommittee. Can you see it?
Yeah. I'll give the recommendations.
Can you see the presentation?
No. Are you sharing your screen?
I am.
Make sure the document is open.
It is.
Desktop, and then go to share screen. If not, we can do it on our end.
Can you see it now?
Yes. Yes.
Coming.
Yes.
Just a second. Testing for vulnerable and at-risk communities. Our subcommittee members are myself, Meg Brown, co-chair Dr. Renando Banks, Dr. Gary Wilkes, Dr. Raina Whitfield, Virginia Barrow, Tiffany Netters, Carol Smith, Dr. Terry Davis, and Dr. Rebecca G. The goals that we had were to review the statewide testing plan for COVID-19 and antibody testing and quarantine, to review the statewide protocols, which would include the geomapping, barriers, the location of testing sites, COVID-19 mobile testing efforts, the local government's role, and the contact tracing efforts. And we were going to be charged with to help produce a comprehensive recommendation for COVID-19 testing for vulnerable and at-risk communities, to include both symptomatic and asymptomatic persons. The spread of the disease over several countries and continents, this has increased with access to travel and coming in contact with different populations and those people who are living in densely populated areas. Coronavirus 2019 was identified in December 2019 in Wuhan, China, and spread across 216 countries and territories. As of today, the World Health Organization reported that there were 7,410,510 confirmed cases, with 418,294 deaths. The Center for Disease Control and Prevention reported that the United States reported 2,016,027 deaths as of today, and 2,016,027 cases as of today, and 113,914 deaths. And Louisiana ranks 14th in the United States with confirmed cases. The residents of Louisiana did start to show symptoms of the infection in early March, and these infections were underreported due to the lack of available tests, restrictions on who got tested, and delayed reporting of the results of the test. The cost of the delayed testing resulted in the rapid spread of the virus, residual impairment to some survivors, and even possibly death. And this could have also resulted in a burden on the healthcare capacity in Louisiana. The implementation of a comprehensive statewide testing plan would facilitate COVID-19 testing for vulnerable and at-risk communities, resulting in early identification and initiation of treatment of those positive. It would also show an improvement for contact tracing efforts, can contain the spread of the virus, and the reduction in the loss of life. The first presumptive case of COVID-19 was reported in Louisiana on March 9th, 2020. There are confirmed cases in all 64 parishes. The majority are in the New Orleans area. The spread of COVID-19 was associated with the Mardi Gras festivities that were held during February 2020. Governor John Bel Edwards closed schools on March 16, 2020, and enacted a stay-home order on March 23, 2020, to slow the spread of the virus. The rapid spread of the virus and a number of deaths resulted in President Trump declaring Louisiana a major disaster area. As of June 12, 2020, the Louisiana Department of Health reported that there were 44,995 confirmed cases in Louisiana. 33,904 have presumed to be recovered, and that number has not changed in the last few days. And 2,883 deaths due to COVID-19. The committee was given the CARES statewide testing plan on May 22nd, 2020, and it was organized with a background, the Louisiana testing plan, the populations that were to be tested, and the formation of a testing action collaborative, and the plan details. It also included a sentinel surveillance. There was a baseline, 100,000 tests that were done in April. Initial testing focused on the areas of high positivity, and the testing per capita varied across all parishes and ranged from 0.1% to 9.52% per capita. There was a goal to increase the testing by 100,000 per month by using a multi-pronged approach to test vulnerable population, leveraging in-state laboratories resources with coordinated regulatory agencies, geomapping to reduce transport time for specimens, training of staff and personnel in congregate areas. They want to be able to provide comprehensive education into how people use the protective equipment, using infection control strategies, and the guidance on cohorting positive patients. They were also going to use an incorporation of multiple specimen collection types. They were going to use a flexible model in testing to accommodate those in different settings and varying resources with the partner communities. They were trying to increase access to minority populations, rural communities with reduced access to testing, and populations with special needs. The populations to be tested were to be the congregate populations in nursing homes, incarceration facilities, developmentally disabled group homes, and those in assisted living facilities. They were also going to test those in the community populations using the community-based fixed and mobile testing sites. A multi-sector testing action plan, which is called a TAC, was formed to increase coordination of testing efforts and design a collaborative statewide testing model. There were 3 categories of SARS-CoV testing. There was intrinsic testing, state reference laboratories, and out-of-state commercial laboratories. There was to be ongoing and additional testing at mobile units and in driving up testing in rural health centers, churches, local Walmart and Walgreens pharmacies, and Louisiana Fresenius dialysis centers. They were using a sentinel surveillance system with diagnostic and serological testing. Testing at 2 school-based clinics in each of the 9 health regions of the state was to be done at each site each month. The summary of the findings. Dr. Whitfield?
Okay, I was waiting for me. Okay, so our summary of finding, guys, the test plan was basically a starting point, of course, but it was very, very generic. And so there were a lot of specifics and details that we were trying to figure out and a lot of debate amongst the group. There was no specific priority for testing, who to be tested, when, where testing would occur, just a very generic kind of outline of what was going on in the state. There was no gold standard for the tests, and the Department of Health was wanting to collect both serology and virus test data, but they also need to collect data on what platform is being used for each test. We also felt that the plan lacked a protocol for identification of positive COVID-19 cases. The plan did not specifically address contact tracing efforts. The plan did not have a compliance, enforcement, or evaluation component. And the plan lacked what we felt clarity on how the statewide testing would be coordinated. Would there be like a central hub or command center for test distribution, coordination, and identification of test sites, as well as data monitoring?
Recommendations based on the priorities. Collect data on what platform is being used for each test. They are not all interchangeable. Some PCR tests look at 2 genes, some 3. Real world sensitivity is quite variable. Some of the antibody tests look at spike proteins, others at nucleocapsides. The best anyone has is a EUA, Emergency Use Agreement, which is a provisional FDA approval. Include priority for testing. Those who should be priority tests include symptomatic people based on CDC's list of symptoms, asymptomatic people in a congregate settings, nursing homes, jails, etc. Frontline essential workers, including store clerks, delivery drivers, supermarket workers, food processing workers, custodial workers, transit workers. Healthcare workers working in high-risk settings include nursing home staff and contact tracers. Cluster investigations where people are associated with a known close exposure to someone with COVID-19. Develop a protocol for when a business identifies a positive COVID case. Include compliance, enforcement, evaluation component, and contact tracing efforts in the plan. Clarity of how the statewide testing will be coordinated. Will there be a central hub, a command center for test distribution, coordination, and identification of testing sites and data monitoring? Any questions?
Are there questions?
Thank you. I have a comment on yesterday, and Dr. Levis, you can chime in because we just received the final testing plan from the state and the contract tracing. So perhaps your committee will want to look at the recommendations that you have and cross-reference it with the plan that we just received, because some of the areas that you recommended have been incorporated into that plan. And so I would just recommend that you will cross-reference what you have here and update it, because if it's already been incorporated, we don't need to re-recommend that to the governor, because your report is what's going to go to the governor saying this is what is needed, is not present, is a gap or a deficiency or a hole in the current testing plan. Dr. Levis?
Yeah, unfortunately, the final plan, I'm not sure when it was released, but I didn't get a copy of it until yesterday. And I shared that with Dr. Brown as soon as I got it. So it's hot off the presses, I think. So you want to check that. Like one of the statements that you made in your presentation, that there was no serology tests had full FDA approval. I'm not sure if that's true any longer. I do think that there are some tests that are no longer on emergency use agreement authorizations. And then the question I had is, did you assess what the degree to which the plan it covered the entire state? And specifically, I'm talking about rural areas. I'm talking about low income communities in urban areas, and also the issue of the times of operation and days of operation of the testing sites, and whether they meet the needs of those communities where they're located.
We did have that discussion. And I think Dr. Wiltz was very passionate about the 64 parishes that in the state of Louisiana, because they do have different needs. We looked at all the available testing sites. We found that there was not a standard in that whether the hours, the criteria for who could be tested, and fees, as the fee schedule as well.
Yeah, this is a really important issue. I would hope that the report would really drill down on this issue to make sure that the testing sites are in the communities where they're needed, and in particular the communities where people of color live and low-income people, but not just that the sites are physically in the right places, but that they're open at the times that are appropriate for those communities. And I know that's going to vary from one community to the next, but that just to ensure that whatever the needs of that community is, that they have sufficient coverage to make sure with the testing sites.
Okay.
Dr. Levice, this is Terry Davis. You know, with our mobile testing here in low income, predominantly African American areas and in rural areas, a lot of that is the capacity. We send mobile units out, people drive by in their cars, but we have the capacity to only visit, say, a church for 4 hours a week or a rec center for 4 hours a week, depending on what the community's needs. But it's like, I don't know how we could be available longer periods of time. With the
Let me just say, yeah, this is Dr. Wiltz. That's why you have to have a 64 parish or a regional strategy to get input from the community, those that know our community. We're about to do an aggressive testing of 1,000 people in the next 2 weeks, and we're setting it up right now in coordination with the Office of Public Health and some of the other providers, and we're going to go, and we know all the nooks and crannies, and trying to get a representative sample of what we're trying to do for the Centene study. I think you're familiar with Dr. Levice. But it goes, the planning coordination that was referenced in there was with the input of those communities. So we don't tell a community, this is how you have to do it. It's not cookie cutter. And I think that's the point that we were trying to make in that committee, is you've got to be community responsive in the way that you are presenting the testing. If that includes extra hours, after hours, or off hours, then we have to adapt to that and make ourselves available with the resources we have to reach that population.
Yes, I mean, I think that's exactly right, and I think it would really be important for this report to address that issue, and just to comment on that and make sure that we are covering the communities in the ways that they need to be covered so that people can get the test. So, but anyway.
Dr. Davis, can you hear me?
No. You're breaking up, Dr. Davis.
Hello?
Okay, here.
Yeah, Dr. Can you try again? You were breaking up a bit, but I think you're clear now. So can you say something?
Okay, we'll circle back to Dr. Davis.
I'm traveling. Is that better?
Won't you hang up and call back? Yes, yeah. Let's circle back to Dr. Davis.
Yes, I just can. Okay, can you hear me?
Yes.
Yes, I can hear you. I don't know if you can hear me.
It's spotty, but try again.
All right, I'll try again. Is that better?
Yes.
Okay, I was just going to comment that my hospital was one of the 11 vendors awarded via the state's testing plan. And to Dr. Wiltz's point, the testing is supposed to be coordinated through the regional medical directors through a task-oriented driven process, because the regional medical directors for the Office of Public Health know the community and should be utilizing the data available to them and directing us to high priority areas that have had low density testing. And that I've only been in contact with the regional medical directors in regions 1 and 9. Region 3 is another area that we also will cover. but we should look into making sure that that is being followed around the state so that there truly is a 64 parish endeavor that is funneled through the community stakeholders.
Okay.
And this is Daniel Sarpon Xavier. I was going to say that with the issues with testing, it might be important for the community engagement group to interface with this group to kind of see some of the recommendations that may involve maybe engagement of the community and make sure that the strategies are ones that would be effective in terms of reaching the various segments of our population.
Any other suggestions or feedback?
I'm curious as to the investment that we're going to make on the testing. It seems to me that there's a lot of conversation about testing to see if there's a positive or a negative test as opposed to the testing for the antibody. And then ultimately, someone could test negative today and turn around and be positive tomorrow. Finally, I'll say this. There are a whole lot of folks right now who are behaving as if they are negative. And if we do extensive testing and let folks know that they are, I think our inappropriate behavior in terms of mask wearing and hand washing and others will only increase. So I'm not certain that massive testing is our answer.
This is Keith Ferdinand. The antibody tests, there are 15 different tests. All of them have different degrees of false positives, false negatives. So that's not the way to go. Plus, we don't even know if you get a positive antibody that you're immune to the condition or how long it lasts. The reason you probably have to continue to test is because you want to catch outbreaks before they become out of control. For instance, a cluster of people in a social and pleasure club, a church that's opened up and the choir has been singing. There was a case in Washington where approximately 6 to 8 people were infected by one person who brought it to the church, and they had choir rehearsal and he infected everybody. So testing still is very important. The antibodies, not so much so, but in terms of finding those positives and the fact that you're negative one time and positive 2 weeks later or a month later still is important, because you can catch a cluster before it becomes very widespread. If you go to the CDC website and you just Google church infection coronavirus, you'll see what I'm saying. There's the actual little cartoon. They show all the people who got infected by this one guy. In Korea, when they opened up the bars, one guy went to several bars in South Korea and infected almost 100 people. So you need to continue to test because you're going to have these clusters.
Yeah, I agree with Dr. Ferdinand. And let me just add, we have one of the things that we're doing, and I don't know if we can make this as a recommendation. In our system, we have kept a record of all the people that we tested going back to November, December, January, that came into our clinics that were testing negative for flu and strep and had some sort of viral illness. And I'm sure all of us who are treating patients, they swear that they had COVID. So we're going to reserve serology testing or target them just to see what kind of numbers we're getting from those that, and I think we all know people that said, you know, I think I had this. And the most extreme was we had someone in our community that went to New York in September and came back, healthy guy that wound up on a vent, and no one could ever figure out what happened with them. That for all the life had everything that's compatible with it. So I think that can give us some sense of, that'll be interesting as a sidebar to see those that I'm sure we've had relatives, friends, patients that we were not certain if they may have had something, that if the test proved to be valid, that can be valuable information just to establish a timeline going back.
Yeah, Dr. Wills, we had at Daughters of Charity and now DePaul system, this is Dr. Hebert, we've had, we did a lot of early testing and a lot of positive tests came back. We have since are in a study where we are retesting those folks that came back with positive COVID-19 antigen or just a viral PCR test, and over 60% of them are coming back with their antibody test negative for IgG and IgM. So it's going to be a wild ride here. We're putting together the data now.
That's great.
Are there any other recommendations or comments?
I think one of the things that can help us be more successful with the testing here in Baton Rouge is that when the advertisements that are on, if they would tell the people where this week they're doing tests, because it's ever changing. The federal qualified health centers now are doing the test, but last week, Baton Rouge General and Our Lady Lake were doing the test, but there never was a announcement given out to the public. So you almost have to, you're running, trying to find out where the tests are, and it changes. It just changes. It's been changing ever since for the last 2 months. So somewhere, somehow, even if you go on the website, and then they list all the sites that are, the testing is available, and maybe 2 or 3 of those now are shut down. So people go from place to place trying to find out where to test, and they don't even put down, a lot of times, the times, period, where they can get the test. So when you're spending money on the advertisement, it'll be more successful. You can tell the people where the tests are this weekend, what the time periods.
So just to recap here on some of the recommendations that we've heard to facilitate the work of this task force would be, 1, to update and cross-reference your final report with the final, this report with the final statewide plan that you all received last night. If there is anything in the plan that you have already recommended, then our recommendation is to eliminate those recommendations because they have been incorporated. Secondly, recommendation would be to incorporate or recommend or explore if the statewide testing plan includes a 64 parish plan that fully addresses the needs of the community. Thirdly, to have maybe the co-chairs meet with the co-chairs of the Community Outreach Engagement Subcommittee to explore if there's a synergistic recommendation as it relates to the community and testing, and have that, submit that as a recommendation. And thirdly, I think what we're hearing is some type of real-time means of where to go to get testing. It could be in the format of an app that the constituents would want to know where to go, or our citizens would want to know where to go. They can go to that app. It'll show all the testing sites for that day, where it is, a GPS location. I do know that Merck and Google are trying to develop this type of go-to app. And this may be something the state may be able to do for easeability of testing. Instead of just going to the website, have an app that they can click on, and it'll show the testing sites, the times, and the GPS location. So this, I think, is what we're hearing as some real-time suggestions that may not be part of the statewide plan that we could recommend. Any other recommendations or feedback for this subcommittee? Dr. Levis?
Nothing more from me.
Okay. Dr. Meg Brown, do you have any questions or any other?
No questions.
Feedback? Okay, so we'll just ask that you all incorporate the recommendations that we're given today and resubmit the plan to us, and then we'll then forward it to the executive committee for review. And we thank you, and we thank your committee for the work that you have done. Okay, we'll move forward to the data and analysis subgroup.
Good afternoon. This is Simone Rambotti from Loyola University. I will share my screen to present our report. Can you confirm that you can see the screen?
Yes.
Great. So this is the final record for the subcommittee on data and analysis. I'm Dr. Rambotti, chair of the committee, and I work with Dr. Katz-Marzik, Dr. Harris, and Dr. Sarpong. Our goals were to produce a comprehensive statewide report on COVID-19 data, and we wanted to look at a number of variables, including gender, age, race, ethnicity, and geography. We wanted to see the distribution across these relevant variables of number of positive cases, tests, hospitalization, and mortality data. We were also hoping to look at some special populations like nursing homes and prisons and comorbidities. The problem, we cited the Robert Wood Johnson Foundation brief on the health equity principle for state and local leaders in responding to reopening and recovering from COVID-19. This was shared with all the members of the task force, and I'm directly quoting, pandemics and economic recessions exacerbate disparities that ultimately hurt us all. Therefore, state and local leaders cannot design equitable responses and recovery strategies without monitoring COVID's impacts among socially and economically marginalized groups. So following this principle, we started working on this. The background is that essentially we were tasked with obtaining and analyzing COVID-19 data for the state of Louisiana. These data are housed by the Louisiana Department of Health. Some of this data, but not all, are presented on the Louisiana Department of Health coronavirus dashboard, which is accessible online. The dashboard reports some data that are directly relevant to our work. For instance, they report mortality data by race, ethnicity, gender, and by underlying conditions. They also report deaths by race by LDH region and deaths by age. Additional data for our analysis were directly provided to us by the Louisiana Department of Health. So we received data through May 18, 2020 of 193,429 tests. And I would like to specify that this is one record per tested person. This data included some information on some but not all the variables of our interest. I'm going to present the evidence at the state level and at the level of Louisiana Department of Health region. First thing I wanted to clarify again that we're essentially looking at two different samples. One sample is the data on tested, positive, and admitted. And again, this comes directly from the Louisiana Department of Health to us, and the data are collected through May 18. Then for the data on deaths, we collected them from the dashboard. We collected them, the data were updated up to June the 5th, and unfortunately, there is no link between the sample of tested and this sample. So while we can compare proportions across variables, we can directly link the two data sets. So this matters because when we look at state totals, we can say that we have 193,429 tested people, almost 17% of which are positive, were tested positive, for a total of 32,701. Almost 17% of which were admitted in hospital. We have 5,453 admitted, which is slightly less than 3% of the tested in this sample. As for the total of deaths, we have 2,798 deaths, but again, we can't say that this means this is a percent of these 193,000 plus, because the individual data are not linked, and they were collected at a different point in time. Okay, so I'm going to present the distribution with these visualizations, and I'm going to start with the, again, state level. As you can see, we have, first of all, race. We Some of the data we received were had like finer distribution of race. So we have, for instance, data on Asian, data on Native and Pacific Islander. Most cases that were combined in another category. So we collected a population benchmark from the US Census, which is the first column that you can see. So essentially, when we proceed left to right in each racial group, we see the proportion of people in each group that was that exists in the population, that was tested positive, that was admitted in hospital, and the percent of death. And as you can see, essentially is that Black or African American are disproportionately affected by COVID. The percent tested is, surprisingly matches perfectly the percent of Black or African American in Louisiana, but the percent of positive is much higher than this. This percent increases further when we look at admitted, and it's still very large when we look at deaths. While, as we see for white population, essentially this population is less negatively affected by COVID compared to Black. And as you can see also later, we have a large portion of unknown cases, unknown races in this case, in the tested and positive population. If we move at gender, we see that women are more likely than just population distribution to be tested positive, and even to be admitted to hospitals, but they are less likely to die by COVID-19. Unknown here is low. When we look at ethnicity, what you see probably first is that there's a large portion of unknown ethnicity. We see that net of this unknown, the portion of Hispanic that are negatively affected by COVID is lower than the percent of Hispanic population in Louisiana. And as for age, you see a very sharp gradient, which it's not particularly surprising in terms especially of percent of admitted and percent of deaths. Now, moving to regions, just as a reminder, two different sources. The source on tested, positive, admitted is the same that we use at the state level data, comes directly from the Louisiana Department of Health, and we have data up to May 18. While I collected from the Louisiana Department of Health online dashboard deaths data on June the 7th, okay? And also in this case, there's no direct link between the two samples, but we can see proportions. If somebody is not familiar with the regions for the Louisiana Department of Health, this is a map that connects the 64 parishes to the 9 regions of Louisiana. So I'm presenting visual data only for race. I realize that these are like small pictures, so I'm going to show a couple more where we zoom in on selected regions. But we can already see that the overall pattern that we observed at the state level is strongly confirmed overall. I chose some regions to look at a couple of important things. For instance, one question one may ask is whether the disproportionate impact of COVID on different races holds across regions that have different racial composition. And the answer is essentially yes, because for instance, you can see on the left, region 1 that has a larger percent Black in population versus region 5 on the right that has a smaller percent Black in population. And in both regions, the percent of the share of Black population that is hit by COVID-19 is larger than the population. Other thing that is worth pointing out with regard to regional variation is the variation in the percent of unknown. So for instance, if we look at region 7 on the left, the percent of races that are classified as unknown is below 15, while it gets to above 30, for instance, for the percent tested in region 5 on the right side. For ethnicity, the overall pattern is consistent with the state level data. And the only thing that we notice is, if you will, an even wilder variation in terms of the unknown ethnicities, meaning that the range of ethnicities classified as unknown varies between approximately 24% in region 7 to 85% in region 5. And as for age and gender, the regional pattern is consistent with the overall state level pattern. In summary, our findings show that when it comes to race, Black population is affected more by COVID-19 than the white population. And this is a strong pattern that is consistent across all areas or across all regions. In terms of ethnicity, 5.2% of Louisiana population is Hispanic. There is a large proportion of unknown in the tested sample and also in the deaths data. But net of the unknown group, we found no evidence of Hispanic being disproportionately affected by COVID. In terms of gender, we notice how women are more likely than men to be tested positive and admitted, but men are more likely to die. 54% of those who died were men. In terms of age, we saw a very strong age gradient, where the greatest risk of being positive and admitted is among those aged 60 years plus, and the risk of deaths increases sharply after age of 70. 67% of deaths were of people aged 70 or more. However, we also noticed that the percent in terms of overall health burden, the percent of middle age groups that is admitted to hospital is all but trivial. In fact, for instance, if we look at the age group 40 to 49, 10% of this group was admitted to hospitals. In terms of regional variation, we saw the data disaggregated by LDH region largely confirm the statewide patterns, but there is, as we mentioned, this wide variety in the unknown. Our recommendations reflect pretty much essentially the data limitations that we have, meaning that the recommendation is that these gaps in data will be filled in the future. So as mentioned, the dashboard as of June the 7th reports 434,000 tests performed. We had data available only on a sample of 193,000 tests. We don't know this sample, whether it is and to what extent is representative of the overall population test. We have a large amount of missing information on the data that we received. 22% missing information on race, 41% missing information on ethnicity. We don't know to what extent these are missing at random or missing in some systematic way. Thus, we don't know to what extent this missing data may bias our estimates. We never found this. As far as we know, there are no disaggregated data available on prisons and nursing homes. We only found eventually some data in terms of totals, total cases or total deaths. We never received data on comorbidities, so we couldn't do anything about that. Finally, we were hoping to get data by zip code, but these also were not provided. The lowest geographical level was the LDH region for testing and positive. So it would be ideal to have lower level data, up to, if not parish, up to the zip code level. So it could be possible to, examine variation across zip codes and find for possible predictors, search for possible predictors. Finally, as we pointed out, there's a lot of variety in the quality of data across testing sites. So hopefully there could be a standardization of testing procedures so that we avoid the potential large amount of missing data. That is it. Thank you.
Well, thank you for that report. I think that was very helpful to see. I note that in that last series of slides, you titled those slides as recommendations, but
Yes.
comments are not stated as recommendations. They look more like conclusions or findings. I mean, it would be good to list specific recommendations so that we're making specific asks of the governor. So for example, you said that there were over 400,000 tests, but you only had access to a little under 200,000 for the analysis. And that's not a recommendation, that's a finding. Your recommendation is you need to get access to the other 400,000 cases. So if you could like state those, what you have there, they're fine as findings, and if you title them as such, that would be good. But we would really appreciate having some specific recommendations of things, actions that you want to see the governor take in this area.
Sounds good. We'll do that.
This is Keith Ferdinand. The percentage of the Hispanic population you had at 5.4%, was that the same as the percentage of persons who was tested across all your various regions?
The percent that I mentioned was at the very end was 5.2%. That is the estimate from 2019 U.S. Census of the Hispanic population in Louisiana.
Right. So the percentage of tested persons who were tested, percentage of all your tests that self-defined as Hispanic, was it similar to the population?
It was lower.
Okay, one of the problems in the Hispanic community, and this has been shown, I'm a cardiologist in cardiovascular disease, is that many times they don't come in for tests, they don't come in for diagnosis because they're afraid of being reported to ICE. And even persons who have a legal status here have that concern. So one of the recommendations may be is that we recognize barriers for the Hispanic population seeking diagnostic testing. Someone who doesn't get tested still gets sick. And even if they don't have insurance, they show up at the hospital, so they're going to be cared for. So we may as well do some diagnoses ahead of time.
Sounds good. We're gonna add a comment regarding this.
I was going to add to that as well, and this is one of my initial comments when we first were added to the conversation: the lack of data on the Latinx community. The numbers just don't add up with what we're seeing nationwide. North Carolina had 42% representation of Latinx folks with coronavirus. New York City found 30% of its deaths were Latinx members. And so I'd be concerned, much like Dr. Ferdinand, that we're missing a huge segment of data, particularly on the Latinx community. The other two groups that aren't even mentioned are our Asian community, especially in South Louisiana. We've got a large Vietnamese population, and then our native populations. And we haven't even had any conversation about our native populations, and they are disproportionately affected. As I've spoken with the United Homa Nation and found that they've had a number of deaths and not being recorded.
Let me add to that also that I recently saw some data, which I'm happy to share with you, for Jefferson and Orleans Parish, showing very high rates of infection among the Hispanic population here. And so I think that bolsters this idea that they're just not being counted, but the cases are out there. And I think that needs to be added as a recommendation, that we need to get good data on Hispanic, Native American, and Asians as well.
Sounds good.
Where are all the data sets coming from? Because, I think it was so chaotic in the beginning, and the tools that people were using to collect demographic information wasn't standardized. So I think that caused a lot of confusion. But I couldn't see on that first slide if you referenced all the data sets that they were drawing their conclusions from.
The data set was provided to us by the Louisiana Department of Health.
That's where okay. Okay, all right. The one you, Dr. Levis, the one you referenced, who did that study that you just referenced?
That data is coming from several healthcare organizations in this part of the state. Much of it is from Ochsner, but it's also it's several different organizations here.
So I would like to add, I was looking back at the data. One problem is also that there was some inconsistency in how the races were categorized. Just to give an example, we were able to get from the data that we received at from the Louisiana Department of Health, the positive, the number regarding positive test was broken at the Black, white, and other level, so 3 categories. While with regard to admitted, we had finer data. So we also had data on American, Native American, and Asian. They are low, like they're small numbers. Like for instance, we had 70 Native American that were admitted to hospital in the whole state. And we could not compare it with any other number, whether it was, we could not compare it with the testing, we could not compare it with the deaths. So we just agreed to the other level. But I agree with all of you that ideally it would be better to have more a richer categorization of race.
Hi, this is Margarita Echeverry. I am Latina and work with the Latino community here in New Orleans. And I tell you that when you ask us what is our race, usually we said other, because we don't categorize us in the specific classification of races. So this is something that we really need to educate the people who are doing data collection about the classification of Hispanics or Latinos in the races. As you know, there are many Latinos that are Black or white. So that is an important consideration. And the Hispanic apostolate has done very good campaign doing COVID-19 testing among the Latino communities. And they always specify very clear, they are not asking for immigration status. So there are lines of Latinos doing the test with the Hispanic apostolate because of the trust the community have with the institution.
Okay.
So this is Daniel Sarpon, a part of this subcommittee. One of the things that we deliberated in our meetings and as we revised our report in terms of framing the recommendations as suggested by Dr. Levis is the fact that I think that there needs to be some standardization of data collection, right at the point of testing all the way down. I think maybe we might not be able to do much with previously collected data, but if we're going to address these issues, more aggressively, then we would need to have some level of standardization in terms of data collection, and to at least have as much completeness when it comes to the data collection. Otherwise, we'll be in the same predicament as we've always been in. So I know that was one issue. There may be more resources that might need to be dedicated to this effort, at least to be able to get our hands wrapped around the issue. But those were some of the things that came as a result of our subcommittee deliberations, and we'll make sure it makes its way into the recommendations.
Are there any other recommendations? Okay, just to recap, we're asking that this committee look at its recommendations section and reframe the findings and state it in the context of a recommendation. State what the ask is as opposed to stating what the findings are. Include a recommendation needing data upon Latinx, Asian, and Native American populations as it relates to, and state the specific data that is needed in those populations. Include a recommendation regarding consistency in classification of ethnicity or race as it relates to the collection of demographic data. And lastly, standardization on data collection moving forward. You can't go back retrospectively to rectify this, but to standardize all the data collection moving forward, and to allocate resources for this.
I would only make one slight amendment to that. Is that don't leave the findings in, but add recommendations. So retitle what you have there as findings, but add specific recommendations.
Sounds good.
Okay. Okay. Thank you, Dr. Rambotti, and thank you, your entire committee, for the work that you've done on this subcommittee efforts. We appreciate your efforts.
Thank you.
There was someone added into the chat a comment about data warehouse. Lisa Van Hoos, could you unmute and just elaborate more on what that would mean and what your proposal is?
Yes, sir. So one of the recommendations would be for us to create a data warehouse, which would basically be integration of data from all these different sources, which could be the local data sets that each subcommittee may be creating on their own, and then also the data coming from these external sources. It would help with accuracy across the subcommittees, and also with us getting a more thorough picture of what's going on at both a parish, a regional, and a state level.
That's a recommendation really for this task force, and I think that's an excellent recommendation, and I'd like to propose that we adopt that recommendation and ask this subcommittee to take that on, unless there are any objections from anyone, any committee members.
No, I don't have an objection. This is Peter Kaczmarzyk, and I'm on the subcommittee as well. But I'd just like to clarify that we never received actual data in terms of person level data. We did not get that from LDH. And that's typically what you would see in a data warehouse, it would be a data set. What we received were aggregated tables of counts and percentages, of tested and of admitted, and relying on what was on the dashboard. And so we had a person at LDH that was working with us to provide us with reports that we requested, but we didn't actually have access to the raw data or anything like that. So what we have are essentially some reports from LDH. The subcommittee doesn't have the ability to, get into that raw data. It would take months to figure out, all the intricacies of analyzing that type of data, which LDH has that capacity. So I just wanted to clarify that, we don't have data per se. We've got, aggregated tables that Dr. Rambotti was able to work with.
Okay, so during the presentation, a comment was made that we didn't get data on comorbidities. Did you request that data and not get it, or did you not request that query be run?
Yes.
We did request it. We did request it a few times, and we didn't receive them.
So I think we need to add a recommendation to your report that refers to access to data. And I'd like to see the recommendations be stronger, because if we're making requests to get data and they're not giving us the data that they're requesting, we need to act on that.
Excellent. Yeah.
I don't want to throw the Louisiana Department of Health under the bus. I think they might be working under some pressure, and they did what they could. I don't know the quality of data that they have to begin with in terms of, these, the quality of like comorbidity data and so forth. But we worked with what we had.
Okay, are there any other recommendations or feedback for the data and analysis subcommittee?
Just one more point, because I know that people are very interested in nursing homes and in prisons. And, we were unable to find any data that was disaggregated, by age, race, sex, ethnicity. Just some reports on the Department of Corrections and the LDH website, respectively, that had, counts of total cases. Now, I don't know who we have to work on in order to get that, but I guess that'll be a strong recommendation from us as well, to be able to get that sorted out. And maybe the prisons or the nursing home subcommittees could comment as well, because I know they've been trying to get that data and it's been rather frustrating.
Hi, this is Shalina Davis, one of the co-chairs of the prison subcommittee. We'll be presenting in in 2 more presentations. So we actually have a recommendation based on that data because it isn't complete. So we have a recommendation around that and we'll present on it shortly.
Okay, any other recommendations or feedback? Okay, thank you very much. We'll be moving to the nursing home resident subcommittee group.
Good afternoon. Can everyone see the screen?
Yes.
Okay, awesome. My name is Dr. Alicia Bates. I, along with Dr. Janine Thomas, are the co-chairs for the nursing home subpopulation group. Some of our other committee members, Dr. Leanne Fowler, Dr. Kathleen Tate, Miss Cindy Schneider, and Dr. Lisa Van Hoos. Some of our priorities and goals, we had it on our previous presentation, but our first goal was to explore the impact of COVID-19 on special populations, specifically nursing home. We were tasked with examining the number of positive cases, deaths, age, gender, race, and geographic location. And then our second priority or goal was to develop a comprehensive plan to address safety and prevention of COVID-19 in the nursing home residents. So as a committee, we focused a lot of our efforts and time on reviewing the current data pertaining to Louisiana's nursing homes. And we found that the COVID-related deaths in the nursing homes is very alarming and it warrants our immediate attention. As of June 1st, so this would be last Monday's data, there has been 1,152 deaths among nursing home residents. And that number still represents about 40% of the state's overall death toll. So since the outbreak of COVID, new regulations and procedures have been implemented among Louisiana's nursing homes. And so in compliance with the CMS, all licensed facilities are required to report certain measures to the LDH as well as the CDC's National Healthcare Safety Network. These measures include the number of positive cases, the number of deaths, and the number of positive COVID-19 staff cases. As of June 1st, there has been 4,739 positive cases in nursing home residents, and as I mentioned, 1,152 deaths in nursing home residents. So since May 18th, all 278 facilities have reported weekly data. But as we were just discussing, there has been no demographic data reported on these weekly reports, which is yet another concern. Without knowing the demographics of the nursing home residents, it'll be very challenging to discern the inequities among this population. So according to the Institute of Medicine, health equity is defined as providing care that does not vary in quality based on personal characteristics such as gender, ethnicity, geographic location, and socioeconomic status. Health equity means giving patients the care that they need when they need it. And differences in demographics, as we know, can shed light on those very specific needs that they have. So now I'm going to turn it over to Dr. Janine Thomas. She'll talk about some of the other data overall for the nursing homes. Dr. Thomas. Can you guys hear me?
No, we can hear you.
Did you guys hear what I presented on?
Yes, we did.
Okay, so we're just waiting on Dr. Thomas. Okay, I didn't know.
I'm sorry. Can y'all hear me now?
Okay, yes, we can.
Good afternoon. The current state of Louisiana, as we stated, there are a total number of nursing homes of 278. The total resident census is 23,000. There's a total of 4,739 resident cases, positive COVID cases, and there's a total of 1,904 of those residents who actually recovered. There's a total of 1,100 deaths. There are also staff cases include 2,010, and there is a total of 1,398 total that staff recovered. And based on what we were looking at, one of the key points that was mentioned from the previous subcommittee, we have requested the variables related to the demographic data, including the age, the gender, the race, and the geographic location. We were told that that data was not available. It was insufficient data based on how the nursing homes were reporting the data. So that was a big concern of ours because we know that was one of our goals. On this slide, we put the information related to the last 3 weeks of cases, deaths, and those that recovered. And as you see the number of residents that's continuing, the resident cases, as well as the staff cases, as well as the resident deaths. But what was significant to me about this slide, again, what was already mentioned, the inconsistency of data collection. Because if we can see in the earlier weeks, we did not have all the different variables that we could look at the data. And again, we still missing those key pieces of the data. The next slide talks about the top 4 parishes with greater than 50% of death rates in nursing homes. We are aware that St. Tammany Parish has a total of 100 deaths and 166 in the total parish. St. Landry has 44 deaths, total of 54 parish deaths. Cato has 111 nursing home deaths with a total of 210 deaths. And St. John the Baptist have 43 nursing home deaths with a total of 83 parish deaths. So St. Tammany nursing home deaths consist of 60% of the total parish deaths. St. Landry is 81. Cato is 52.85%. We are aware that there are other parishes who have high death rates, such as Jefferson Parish and New Orleans Parish. However, those death rates do not account for over 50% of the parish deaths. So we find that to be really significant. Back to Dr. Bates.
Can everyone hear me? So now we're going to talk a little bit about some of our current recommendations that the committee members, along with Dr. Thomas and I, have come up with. Since we realize that COVID-19 can lead to deadly outbreaks, it is imperative that we have standardized evidence-based practices that are implemented to ensure the safety and prevention of COVID-19, as well as to decrease Louisiana's nursing home deaths. So the CDC has developed some key recommendations and strategies that they want all of long-term care facilities to implement. And we kind of aligned, or we came up with a platform that we're calling the 3 T's plus the double C's that kind of aligns with the CDC's key recommendations. The 5 elements that make up this platform include testing, tracking, trending, compliance, and capacity. And so we have recommendations that fall under each of these elements. So we'll start by talking about testing. We realize that Louisiana has a statewide testing plan, and we reviewed the current guidelines, and the recommendations that we make are above and beyond what is mentioned in that testing plan. So the main gist of the current guideline is that all residents and staff must be tested. That's what the guideline says right now. Some of our additional recommendations that we are proposing would be that all residents should be tested upon new admission to the nursing home, as well as prior to readmission. So if the resident has to leave to go to the hospital and then they are readmitted back to the nursing home, we are requesting that they are tested for COVID and that those negative test results are confirmed before they come back to the facility. Ideally, we would like to use same-day testing just because the results are quicker. And then as far as when the nursing homes open back up, we have a recommendation that maybe a maximum of 2 designated immediate family members can visit at the facility, and that those members are tested weekly as well. Our second recommendation is that all nursing home staff should be tested upon hire. So once they are employed at that facility, and they are also weekly tested throughout the duration of their employment. We want facilities to encourage that any employee that turns out positive, that they self-report. And we also wanted to consider that a lot of employees have multiple jobs, so they may have a second job. And if they do, then they need to report that to the facility, because that would certainly put them at a higher risk. For instance, if they were to be exposed to COVID at one position and not the other. So tracking, the current guideline is that contact tracing will be conducted for close contacts of laboratory confirmed or probable COVID-19 patients. And then the other guideline is to assign an individual to manage the facility's infection control program. So what we're proposing is that for any nursing home facility with less than 100 residents, then it will be the nursing home's duty to assign an individual and train them as a contact tracer. And then the facilities that have more than 100 residents, they should utilize their infection prevention and control coordinator as the contact tracer. We're also recommending that LDH assign at least 1 contact tracer per region to monitor the positive staff cases. So what we were hoping is that the nursing home, whichever individual is assigned as the contact tracer in the nursing home, they would actually monitor the positive cases and contacts for the residents. But the LDH assigned contact tracer would monitor the positive staff cases and contacts. And we were trying to split those up because simply, as we mentioned, some staff work at multiple facilities. So it would behoove us to do more of a regional level of tracing them versus just doing it within the nursing home. And then we also are recommending that contact tracers collect accurate demographic data. So as we've all mentioned multiple times, we're lacking in age, gender, ethnicity, and geographical location. So maybe we could kind of close some of those gaps by having our contact tracers collect some of that data, which would then be reported to the LDH, and they could actually aggregate it and keep up with that data. So. Dr. Thomas?
Trending. Current guideline is to assign an individual to manage the facility's infection control program. Our recommendation is a 5% increase of positive cases during the weekly testing requires a return to phase 1. Recommend that LDH aggregate and trend demographic data, what we mentioned earlier, on all positive resident and staff cases. And LDH collaborate with the COVID-19 Health Equity Taskforce, specifically Nursing Home Subcommittee, to ensure that the necessary demographic data is obtained for the nursing home population. Compliance. The current guidelines under compliance is that CMS is requiring nursing homes to report COVID-19 facility data to the Centers for Disease Control and Prevention and to the residents, their representatives, and the families of the residents in the facilities. So our recommendation include all nursing home facilities should examine their current COVID-19 policies and procedures for compliance with the established CDC, CMS, and LDH guidelines. 2, lack of compliance should be addressed by administration and a performance improvement plan should be developed and implemented. And 3, all nursing home facilities should conduct weekly compliance audits that are recorded and tracked. Capacity. Didn't really find any current guidelines related to capacity for what we are referring to. So therefore, our recommendation is that we recommend frailty education and training among all nursing home staff and employees. And number 2, at minimum, all nursing homes should screen residents greater than 70 years old for frailty using a valid frail scale. The frail scale should be completed by a licensed nurse. And I think this was very important based on what I just heard in the other subcommittee presentation, that we know there's an increased risk in that for patients ages greater than 70. Thank you.
Thank you. We have a chat recommendation from Dr. Davis. She says, I recommend that the committee review and compare the recommendations to the statewide testing plans, as there are congregate facility testing teams being deployed to nursing homes as part of the plan. And so being that we just received the statewide plan last evening, we're gonna ask your committee to cross-reference that plan with your recommendations. And if there is any duplicative recommendations, then just to update it and eliminate anything that's already covered in the statewide testing plan.
Thanks.
Absolutely, thank you.
The only thing I would add to this is there is a new plan that is going to be implemented on visitation at nursing homes. I've seen that plan, and it's going to be implemented currently during phase 2. So the recommendation you had about only 2 visitors is different than what that plan is. But I think if you could modify that recommendation to focus on the testing part of it, which I don't recall that being in the plan. I've read so many of these plans now, I can't keep them all straight. But just in case that wasn't in the plan, to keep that part of your recommendation about the need to test visitors to the nursing homes.
Absolutely. Thank you.
Any other recommendations?
Yeah, this is Dr. Hebert. I had to step out to see a patient really quickly, so I just want to make sure we covered Donald Trump's recommendation about not requiring nursing homes to count COVID-19 deaths that occurred before May 6th. Did we discuss that? If we did, just say yes and I missed it, or if not, are we addressing that?
Dr. Bates, I don't think that was, did you all address that or find any? anything regarding that? I know they had stopped collecting data on nursing homes at some point and then started again.
Yeah, it was like apparently like prior to May 6th, it was like they said that they wouldn't count those deaths or something that was kind of out in the media, and I did a story on it, and I can't remember exactly what the outcome was and whether they were going to start using that again to talk about the deaths, because it became a big issue with the amount of deaths in nursing homes and how we were going to review and address that, because a lot of these nursing homes were privately owned and they didn't really have to report a lot of the data about and how much testing they were doing and that kind of thing. So I just wanted to make sure that we're looking at that so we can have our data appropriate for the state. That's all.
You all may just want to incorporate that as a finding.
Okay, thank you.
This is Amy Lesson from Dillard. I just wanted to make a point, which is that after the last two presentations, I think my recommendation would be that one of the main recommendations and messages coming out of this entire task force be that the state of Louisiana needs to devote more resources towards data collection around anything having to do with COVID-19, but really health disparities. And, I think the last two presentations really kind of are probably even just the tip of the iceberg in terms of the needs of concerted efforts towards really organized data collection that's standardized, which I know that there are lots of issues and problems with how to get that done. But I mean, if we're a task force that is tasked with giving recommendations to the state around health disparities and health equity, I think we need to send a very strong message about data collection statewide.
And I think that theme is going to follow through across pretty much all of our subcommittees, because it's a recurrent void that we are seeing.
Indeed.
Any other recommendations? Dr. Levice, you have anything else to add? Okay, well, thank you, Dr. Bates, Dr. Thomas, and your entire team for your report. Just make a note of the feedback and recommendations that we have given you as it relates to looking at your recommendations to see if there's any duplication since the statewide testing plan has been developed, if there's any redundancy to eliminate those areas. Modify your recommendations as it relates to visitors testing, make an acknowledgement or a finding that for a period of time in May, there was no data collected in the nursing homes. So there is a void of data for a period of time, and make a strong statement to devote more resources regarding data collection from LDH. Okay, we'll move on to our final subcommittee presentation today, and that'll be COVID-19 and Special Population Louisiana Prisons.
Thank you. Can you see and hear me? This is Shalina Davis.
Yes.
Okay, great. So thank you so much. I know we're last but not least, and I'll be mindful of time. So just a quick overview. So we were the subcommittee charged with really looking at and assessing the environment in prison settings. And we actually made a decision as a subcommittee to expand that to all correctional facilities across the state of Louisiana. And our members include the folks that are listed here. Myself as a co-chair, Mike McClanahan as our other co-chair, Mr. Frederick Thomas, Miss Erica Rogers, Dr. Faye Grimsley, and Dr. Connie Arnold. And I also want to acknowledge we have many subject matter experts that help contribute to our report and plan and recommendations. And I wanted to name Professor Andrea Armstrong from Loyola University and Dr. Ashley Winistrom from LSU School of Public Health. Just briefly, our charge was to explore the impact of COVID-19 on special populations, specifically among Louisiana prison populations. And we expanded that, as I said, across all correctional institutes, and then to develop a comprehensive plan to address safety and prevention of COVID-19 in Louisiana's prison populations. And so in just a moment, I want to walk through our plan, and you all saw this because you all have the same headers for your template, but walk through the statement of the problem, a little bit of the background, the data and evidence that we did have, a summary of our findings and our recommendations. So an understanding of the problem, as many of you know, this is from the people angle, Louisiana leads the nation and the world in our incarceration per capita. We have about 50,000 people who are incarcerated across the state of Louisiana in roughly 140 detention facilities, and that includes parish jails, state and federal prisons, and juvenile detention centers. I think it's also important to note that there are about 800 to 900 children who are housed daily in juvenile justice centers. Also, it's important to note that there are roughly 31,000 people who are under state custody. And when we refer to state, we're referring to the Department of Public Safety and Corrections, and that will be the acronym DPSNC. And of those 31,000, approximately 17,000 of the people that are under state custody are actually housed in parish jails on behalf of the state. Also, DPSNC releases about 15,000 people per year who have completed their sentence. Additionally, on the people side, as a group, Louisiana incarcerates people who are uniquely vulnerable to COVID-19 due to both their age and race. So the average age of the state prison population is about 40 years old, with over 400 people who are in prison are at or greater than 55 years old. And then on the race angle, about 2 out of 3 people in our state prisons are African American. Understanding the problem from the facility angle, most detention facilities, due to their design, risk becoming a COVID-19 cluster. The average size of a cell is roughly 48 square feet or 6 feet by 8 feet for 2 people, which is less than 6 foot social distance recommended for the general public. Also, centralized kitchens are the norm, which can also be breeding grounds for COVID-19. And though incarcerated people may live in separate units, staff may become super spreaders within the facility. Additionally, Louisiana detention facilities have historically struggled to provide adequate and high quality healthcare to people who are incarcerated. We noted in our plan that several prisons employ medical staff who have had their licenses revoked or suspended by the Louisiana State Board of Medical Examiners after disciplinary action. So going to some of the supporting data and evidence, and we wanted to talk about the methodology first. As many people have already noted, data and information was something that we really wanted to start with. So as a part of that methodology, our subcommittee did a request for data and information that was sent by Drs. Brown and Leviste directly to roughly 140 emails. That included representatives from the Louisiana Department of Public Safety and Corrections, including Secretary Jimmy LeBlanc, as well as all of the Louisiana sheriffs who actually have jurisdiction over the parish jails. And we received only 6 responses back that are actually in the appendix of our report. We also asked for a request from from the Data and Analysis Subcommittee that spoke earlier from Dr. Ashkar, and I know we weren't able to get additional data from them. And we also, this was important to note, we did utilize the Public Safety and Corrections COVID-19 tracker that I have screenshotted here. And please note that this includes COVID-19 related information both inmates and staff, but only for 9 Louisiana prisons. And you'll see here that it includes information about the current positive symptomatic versus asymptomatic, total test positive, total recovered, and then also it has COVID deaths. However, this data does not include race and age demographic information. Additionally, related to the data and evidence we looked at, in terms of the current crisis for people who are incarcerated, we started from the national level and then drilled down. So first, according to the Centers for Disease Control and Prevention, 46 Louisiana facilities had confirmed COVID-19 cases. 17 reported cases were in both incarcerated or detained persons and staff members. 15 facilities reported cases only in staff members, and 14 facilities reported cases only in incarcerated or detained people. We did note that all of the facilities with cases were located in all of the 9 Louisiana Department of Health regions and ranged in population size from 12 to greater than 5,000. Also, when we broke down and tried to drill down by prison population, by jail population, and by youth detention centers, we found the following information. To date, and again, this was from the COVID tracker that is operated by the Department of Public Safety and Corrections. To date, at least 16 incarcerated people have died, and approximately 612 have tested positive in state prisons. 167 staff have tested positive and 116 have recovered, while 3 have died among staff. However, it is important to note that reports indicate that the Department of Public Safety and Corrections has only administered approximately 1,000 tests out of 31,000 people who are incarcerated in prisons. For the jails, there was no statewide information on deaths or positive infections in jail. However, we did receive information from 6 jails. And then also in the youth detention centers, it was important to note that 28 young people and 49 staff have tested positive in 4 facilities that are managed by the State Office of Juvenile Justice, and no deaths were reported there. Overall, data sources were incomplete. We know that agencies have not released their criteria for testing or defined what is considered a COVID-19 death, which we thought was important on the facility side, and information on staffing and workplace is also lacking. And while we do have the tracker from the Department of Public Safety and Corrections, the data is incomplete for 9 state prisons. And we came to this conclusion because, as we mentioned earlier, DPS&C has at least 17,000 people in local jails. So a roll-up of our findings before we get into the recommendations is that, and this helped to inform our recommendations, was that infections and deaths for people in detention facilities, including staff and people who are incarcerated, are likely to rise. Prisons, juvenile detention centers, and jails have not sufficiently reduced their prison population to enable social distancing or other preventive measures. Prisons and jails have attempted to separate infected people from non-infected without the benefit of widespread testing. Separation measures between positive COVID-19 people and non-infected have not been strictly enforced. The use of solitary instead of ethical medical isolation to address COVID-19 is dangerous. And medical treatment for COVID-19 has been plagued by a lack of staff, a lack of uniform procedures, protocols, and implementation, and has impacted the ability of detention facilities to treat other medical and mental health issues. And the shortage in publicly available information about COVID-19 infections among people who are incarcerated and staff endanger public health. And our big overarching note is that there's no public safety without public health. So for our recommendations, we had quite a few, and we broke them down in 2 buckets. One was immediate term recommendations, and the other was, and I'll walk us through the immediate recommendations. And note that these are just the high level, but in our plan, we spell this out a bit more, and I'll do a little bit of a summary of each. So the first recommendation is that the governor should appoint a statewide independent public monitor over all jails and prisons. And the team, and they shall have decision-making authority, and the team shall represent the following entities: Department of Public Safety and Corrections, sheriffs, legal advocacy organizations, LDH, and other public health entities, and people who are formerly incarcerated. The team shall conduct pandemic safety audits and inspect all facilities. And the team shall collaborate with LDH, OSHA, and CDC for advice and support. And we also recommended that this team be involved in interviewing and getting from staff along with current and former people who are in jail and prisons to assess the landscape. Recommendation number 2 is around, we recommend decarceration or controlled evacuation to enable proper social distancing. And we said the responsible entities would be Louisiana, the state of Louisiana agencies, which is inclusive of Louisiana Department of Health, Department of Public Safety and Corrections, Probation and Parole Division as well. And they shall work in collaboration with parole board members, healthcare providers, and organizations to support this effort. The third recommendation is around evacuating all incarcerated people who test positive to a medical facility for observation and treatment versus solitary confinement. And we propose that this be done in coordination with LDH, Department of Public Safety and Corrections, as well as the Louisiana Sheriff's Associations, and as well as the Covid-19 medical monitoring stations, so that people who are incarcerated can be treated. The next, number 4 is to enable social distancing as the cornerstone of mitigation. And we recommended that, again, the responsible entities would be the state agencies, LDH and the DPS&C, in collaboration with judges, sheriffs, DAs, and the defense attorneys. And we recommended that things like industrial hygienists should tour each detention facility to identify safety precautions taken immediately. We recommended that in dorms and single beds, there should be at least 9 feet placement of those beds to enable social distancing. And we also said, instead of extended like lockdown cells or solitary confinement, there should be medical treatment used for quarantine, especially of both children and adults. Recommendation number 5 is to prioritize testing, hygiene, and sanitation. Our first recommendation was informed by many best practices that are happening across the country in places like New York, Michigan, in the Marshall Project, where we find a lot of these best practices where aggressive universal testing should be done for both people who are incarcerated as well as staff. Also on this includes training and education of staff on proper hygiene and sanitation, and also ensuring that each facility provides a quality soap, hand sanitizer, and comprehensive sanitation of facilities. Recommendation number 6 is around adopting measures to address COVID-19 related to mental health concerns. And that includes allowing people who are incarcerated, especially children, to have frequent contact with their family members at no charge and without limitation, ensure that children who are in custody have the same access to remote learning materials, provide telephonic and confidential access to mental health counseling for all incarcerated people, and ensuring continuous communication by detention facility staff to incarcerated people on COVID-19 conditions, precautions, and exposure. Number 7 on the immediate and final on the immediate recommendations is that LDH, Louisiana Department of Health, work in collaboration with the Department of Public Safety and Corrections to provide real-time publicly available data on COVID-19 deaths, cases, as well as information on each facility's preparedness and response protocols. And a couple of things that went under here that kind of go to the point that folks made earlier is that we believe this data should be collected and include age, race, people who are medically vulnerable, and other demographic information. And for the long-term recommendations, we have 2. So the first is number 8 recommendation is to ensure that we have a deepened capacity to plan, prepare, and respond, and that correctional facilities work closely with LDH regional medical directors and administrators to ensure facilities employ best practices, and that we develop and require adoption of guidelines on use of personal protective equipment inside facilities and periodically publish information on the purchase and manufacturing of PPE. And then the last recommendation on that point is to ensure the development and implementation of an evaluation and impact plan so we know how we did do and how we are doing in the management of the crisis and what lessons were learned. So that is the end of the presentation, but I wanted to open it up to see if any of our subcommittee members have anything else to add.
Good afternoon. This is Mike McClanahan, co-chair with Ms. Davis. And what we had also, we had gathered information statements from persons that were incarcerated, as well as from family members of those that were incarcerated, that pled to us to ensure that the sentences of their loved one, some of them were short-term sentences and some were mid-level sentences, not to be a death sentence for their loved ones while incarcerated. And then we had also a case out of the U.S. federal court case that was backed up by the Supreme Court out of Ohio that that ruled that the Bureau of Prisons should start releasing inmates, those that fit a certain criteria, immediately. So when our recommendations to the governor was that there would be some type of persons coming out, some type of decarceration. It was based upon all those factors. And we were hoping that once we had enough stuff in place that the governor could see and understand that this is something, especially the decarceration, should happen immediately. That's all I have.
Thanks, Mr. McClanahan. Anybody else from our team?
Okay, any other questions? We'll open it up
This is
that you
Dr.
may want to
Ferdinand.
address.
You may have had it in your report. What percentage of the clients are over the age of 65 or over 70?
Well, we only had that information. So we don't have that information by COVID, but we have that information only for state prisons. One second. So just generally, we know that people who are incarcerated in Louisiana, in our state prisons, over 4,500 of people are age 55 and older, but we do not have the age demographics, I believe.
The CDC mentions 65 years of age and older as high risk and should take extra precautions.
Yes.
I actually did an evaluation of Angola many years ago for the ACLU, and I toured the facility, went to their services. There are a lot of older people, some 65, some 70, and I think you probably know this because you're very aware, and they're on death's doorbed. They're ill, they have these life sentences, and it's just crazy because we're paying for a hospital bed, and it doesn't make sense for them to be in an environment in which they're high risk. So I don't know if you can do this, but you may want to consider that they evaluate those patients who are high risk because of advanced age and comorbid conditions, placing them at the potential risk of death and disability from COVID-19. I'm throwing that COVID-19 in there just for window dressing. Really, they had death and disability, period.
Yes.
And it sounds right, life, 20 years, 40 years. It sounds really good to us citizens who are out here, but it's really crazy. We're paying thousands of dollars for elderly, sick people in Angola.
That's right.
Yes, thanks. We will make sure that's explicit, but I know that was a lot. We had lively discussion around that, but we'll include.
Well, I had a question related to that. So if we release those patients, those people, what happens to their health care once they're back out on the street? How are we going to ensure that they continue to receive health care, those that need it, once they're released? I think that we need to make some statement about that too, that we don't just want them to release people and drop them off and then leave them without the ability to maintain the medical care that they were getting, even the inadequate care that they were getting in prison.
Excellent observation. Most of them should be eligible for Medicare. It's a right. And most of them should be eligible for Medicaid. Fortunately, our governor has expanded Medicaid. The clinic services, now remember, I only did this over a decade ago, so it may have improved, but the clinic services are suboptimal. It's not like they're getting care. They're just laying there, oftentimes with an IV or a nurse giving them their insulin, et cetera. And the other problem is, this was mentioned in the report, most of you probably missed it. I was on the Louisiana State Board of Medical Examiners for a decade and a half, president for 10 years. So I know what I'm about to say is true. It's going to shock you. Many of the doctors could not work on the outside because they can't get a license, but they're protected by the state because they're working in a state institution. And they may be men and women, and I'm not casting personal aspersions against them, but would have very sketchy backgrounds as physicians. So it's not like, well, let's keep them in the state institution because they're getting really good care. It's not that way.
Yeah. And to both of your points, we can definitely include the referral to care and think about it broadly. I mean, I know we have the FIT clinic here in New Orleans that Dr. Anjali runs. That's for people who are formerly incarcerated. However, I think we can make note of the importance of linking people to care once they're released from those settings.
You did mention that some of those physicians are unlicensed, am I correct?
We sure did, and we actually named in the actual full report, we did name a couple.
That might have missed many of the people on the call. So I'm going to be quiet, but I can tell you that it sounds right. Keep them in jail, keep them protected, and they're getting care. But the truth is, they're getting very, very substandard care.
Yes, that's right.
To clarify, they're unlicensed or they have suspended licenses.
Their license have been revoked or suspended after review.
Right. So I just wanted to clarify the language there. It's not that they were licensed, they lost their license, or they're suspended. But I think the issue about making sure that there's some continuity once they leave the facility, that they're going somewhere, and that Medicare and Medicaid is available, but they have to be enrolled, right? And so they're going to need help getting enrolled and also getting into care out in the community.
Thank you. Any other thoughts or feedback for us?
Okay, it looks like you only
What
have
about the workers in prison facilities? Was that mentioned?
Staff, yes, we look in terms of their COVID-19 related cases. We included in most of these recommendations, we address both people who are incarcerated as well as staff.
Okay.
Yeah.
Okay.
Ms. Davis, I recommend the same recommendation with the other committees, that you also look at the recently released final statewide testing as it relates to individuals who are incarcerated with testing. And if you have any recommendations as it relates to testing for the staff or those that are incarcerated that's already included, just eliminate that from your recommendation.
Okay, thank you. Will do.
Great job.
Thank you so much, Ms. Davis, co-chair Michael McClanahan, your subcommittee, and all of your subject matter experts who contribute to this cause. You did a great job, as you all have. In closing, on behalf of Dr. Levice and myself, we just want to highlight that we are aware that the country is facing two crises at this time, COVID-19 and systematic racial injustice. And we will be putting together, in collaboration with LDH, the task force will be collaborating with LDH on a joint statement as it relates to recent events and unrest in our country dealing with racial injustice. So we're in the process of putting that together, and once it is finalized, we will be sharing it with the task force. Thank you all for the work that you all are doing. We know that you're working full-time jobs and maintaining your careers and volunteering your service on this. And I just can't reinforce enough that the work that you are doing now will probably be the most important work that you'll ever do. So we continue to ask you to stick with us. We're calling for clarity of mind, stamina of spirit, and tenacity of heart, so that we can produce a meaningful change in the state of Louisiana. At this point, any public comments? No public comment. Wow, we got this done in record-breaking time. It is 3:59. Dr. Levice, you want to reinforce our process now that our subcommittees have just some minor revisions to do to their report. What time frame are you suggesting for them to get these reports back?
Yeah, I think that what we had decided was that we would present them at this meeting, give people a week to make it whatever additional changes or modifications, and then we would submit these reports next Friday.
Okay. So
I guess the committee would officially vote to adopt these recommendations on next Friday's meeting and submit them to the governor immediately.
So if you all could get these minor revisions to us no later than Wednesday of next week, then our task force will have time to review it and adopt it and forward it to the governor by next Friday. Is that doable?
Yes.
Yes. Yes.
And then we'll be notifying the next group who'll be presenting on next week. We'll touch bases to see how they are with their reports. I know we have a report from the community outreach group that'll be ready to report, and public policy. And those two for sure will be reporting next week, and then we'll see where the other subs are as far as ready for reporting of next week. Are there any other comments? Call for adjournment. All right. Everyone have a wonderful, wonderful weekend, and we'll see you all next Friday. Next Friday's meeting will be open to the executive task as well as the subcommittee so that everyone can have an opportunity to hear these wonderful reports. Thank you all and have a wonderful weekend.
Bye.
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 Bye.